So, we're going to talk about Parkinson's and neurogenic orthostatic hypertension. So I've got some definitions of what this means, and my interest in it actually arrived around a lady who presented to emergency department hospital and where I became involved in her care. It made me think about the prevalence and the impact of neurogenic orthostatic hypertension, and then looked at some of the non-pharmacological interventions and pharmacological interventions to help people with this non-motor symptom. I thought I'd throw in the end, what is supine hypertension as well, just to keep you all on your toes. So the question is, why do I feel dizzy and lightheaded when I stand up? And so the words neurogenic orthostatic hypertension are neurogenic because of the nervous system. Orthostatic means related to or caused by being in an upright position, and hypotension means low blood pressure. So essentially, when you feel dizzy and lightheaded when you stand up, it's because your blood pressure can lower due to the change of position. So it's not due to your heart or the cardiac output, but due to the nervous system. Oh, I'm not sharing my screen. Sorry, I just discovered. Sorry, everybody. Sorry. Is it shared now?
Yes.
Thank you. Yeah, sorry about that. It's rambling on. Can I leave it like that? Yeah. Okay. So
sorry, Rachel. Just a reminder for everyone to stay muted while Rach is presenting, and then we can have questions at the end.
Where's muted? Mute. Oh, I see.
Okay. So does that make sense? So instead of being something to do with your heart, it's your blood pressure can lower or go the other way as well because of the nervous system. Okay, and it's quite an interesting and interesting mechanism of how it all works. And maybe I can try and explain it. But anyway, so what happened was, I know that when people end up going to emergency and they've got Parkinson's disease, these are the common reasons why people present. They go when they get constipated, they go when they have swallowing issues, if they've got a urinary tract infection, or if there's some psychosis or cognitive behavioural episodes where sort of family members are struggling to manage. I also know that when people go to ED, it's because they've had a fall, and that's usually to do with reduced mobility, bradykinesia, the slowness, and orthostatic hypertension. So there you go, it pops up again, doesn't it? And we also know that PD patients have frequent and longer admissions in hospital, and there's higher rates of complications and worse clinical outcomes. Not good news. So let's try and work out this orthostatic hypertension and what we can do to stop you having to go to ED with it. So this is a story that I looked after a lady. She was an 82-year-old lady. She went to ED after she had lightheadedness and she had a fall. She didn't have a head strike, which means that she didn't clong her head on anything. I also knew that she'd had Parkinson's disease that was diagnosed in 2015. So that was 4 years down the track. And I'd met her as well. And I knew that she was dizzy when she was standing up. She told me that she couldn't stand for too long, and that when she was preparing dinner and standing and peeling vegetables, she would often get dizzy. And she also noticed that when she was hanging out the washing, she felt quite dizzy and lightheaded. Funnily, she lived with her husband, who was also 90 years old, and so she was 82, he was 90, and they both had Parkinson's. So when she presented to the ED department, we know that she had what we call postural hypertension. So when her blood pressure she was actually lying down, they took her BP and it was 105 on 65. And when they got her to stand up at 1 minute, it was 85 on 50. And at 3 minutes, it was 90 on 55. So they're quite low blood pressures. And when you're connected up to the hospital electronic system, when you punch those figures in, it often elicits an emergency response because they're actually quite low blood pressures, and she wasn't feeling well too. So what am I talking about? The blood pressure. So when she was sitting down for greater than 5 minutes, she had a blood pressure of 105 on 65. So the 105 measurement records a systolic blood pressure, and that's when the heart muscle is contracting, and it's got a lot of pressure. The 65 reading is what we call a diastolic reading, and that's when the heart muscle is at rest. Really clever, isn't it? I think windscreen wipers and sphygmometers that measure blood pressure are probably the best two inventions in the whole world.
As bad as you need.
But what happened when she stood up? So after 1 minute, when she stood up, she felt dizzy and lightheaded. And you can see that systolic blood pressure had dropped down to 100, down from 90 from 105. And also her diastolic had dropped. So we measured that she had a postural drop in her blood pressure. She was symptomatic. She felt lightheaded and dizzy. And she'd said that typically before her diagnosis of Parkinson's, she'd been treated for high blood pressure. I made contact with her GP, and he noticed that he had diagnosed that she did have symptomatic orthostatic hypotension. And he put her onto a medication called fludrocortisone, and she was having half a tablet of this in the morning. When people go on fludrocortisone, and I can talk a bit more about it later, we do have to monitor their electrolytes and particularly potassium. And I noticed that she had some ankle edema and some swelling around her ankles as well. So her medications at that stage was levodopa carbidopa, 250 she had at bedtime, and she was having levodopa carbidopa, which is like Kinson or Cinemet, 1 tablet 3 times a day. She had an Azilect in the morning, and she was also having fludrocortisone because the doctors knew that she was symptomatic and she had a postural drop. Are you all with me still? Yep. Yeah. So what happened next? Well, the doctors decided to increase, this is the emergency doctors, they said, well, let's increase her Flurinef, and they put her up to 2 tablets a day. The doctors felt that her Parkinson's medications were contributing to her orthostatic hypotension, so they ceased them completely. Her diagnosis of Parkinson's was also removed. She was cured. Her postural hypertension appeared to improve, but I put a little note there, temporarily. 4 weeks later, she came back into hospital with another fall and another head strike. She actually hit her head while she was in the shower, and she still had a postural drop. So the moral to the story was, when you look at information and medications about Parkinson's, they say these are drugs that are known to induce or worsen neurogenic orthostatic hypotension. And I go, blah, blah, blah. It's a much maligned drug called Kinson and Matapar. And I guess if this happens to you, please don't let your PD medications be ceased without changed even without consulting your neurologist or your geriatrician. And it's all about getting the balance of getting the right medication to help with Parkinson's symptoms and minimizing BP postural drops. So the moral to my story is that, and I'll go through it in a bit more detail, that it's not just about the medications that cause this orthostatic hypertension. So we know there's a lot of non-motor symptoms in Parkinson's. And if I'm not sure if you can see, but I'm circling this autonomic failure. Can you see me doing that? Okay, so we know that some people, and remember everybody's version of Parkinson's is very different. I watched a webinar by a very clever neurologist in the UK called Ray Chowdhury, and he was trying to explain it to us, why people have more autonomic failure symptoms than other people. And his version was that when there is a loss of dopamine neurons in the brain, which affect your movement, they can impact upon some other neurotransmitters, such as norepinephrine or acetylcholine, and they can present with different symptoms. So we know that autonomic nervous system, and I'll come back down here, regulates our heart, our blood pressure, our temperature, respiration, digestion, and sexual arousal. These happen without me thinking about it. If I need to run, my heart rate knows that it's got to go faster, probably really fast in my case. If I change position from sitting to standing, my blood pressure the arterial blood pressure knows it has to drive up to meet that new requirement. If I am hot, I will perspire. If I'm a lady, I'll glow. If I'm cold, I'll shiver. The autonomic nervous system also controls the smooth muscle of the gastrointestinal tract, which is why it slows down in Parkinson's in some people and has a high prevalence of constipation and sexual arousal. So what happens in Parkinson's when it doesn't work properly? So I'm not going to talk about any of the other things. I'm just going to talk about what happens to blood pressure. So this is orthostatic hypertension. We have a definition for it, and it says that upon standing, if the systolic blood pressure, that's when the heart's contracting, drops more than 20 milligrams of mercury, then we think, or even up to 30, there's a new consensus. We'd say that the person probably has postural hypertension secondary to orthostatic hypertension. And then again, in 3 minutes, if there's still a drop or a slight increase, it can be symptomatic and it can be non-symptomatic. Some people I have looked after in hospital when we've been initiating a drug called apomorphine. I know that the person's blood pressure is typically going to drop quite alarmingly low, but they're sitting up in bed wondering what the arrest team is doing all around them. When these blood pressures drop, there's no compensatory increase in the heart rate. So if somebody has, a low blood pressure because they're dehydrated, their blood pressure drops and then their heart rate increases because the blood wants to pump more blood around the body. But this is to do with the autonomic system. So we don't have these other indicators. And we have to also, again, with Parkinson's, we're always ruling out that there's not another reason for these things happening. So we would do some cardiac investigations, but we probably say if someone's blood pressure drops to this amount or the diastolic even a small amount, with no compensatory increase in heart rate, we'll probably say it's orthostatic hypertension on the background of Parkinson's disease. So I was really curious then. I wanted to know why the Matapar or the Kinson was the sole culprit and why it was removed from this lady's regime of medications because of her fall and due to orthostatic hypertension. So I went back through the databases and I noticed in a couple of studies that orthostatic hypertension can occur in de novo patients. So that means that people who've never been on medications for Parkinson's can also have orthostatic hypertension. There was another study by Palmer and Kaufman in 2018 that said that orthostatic hypertension can occur at all stages of PD. And interesting enough, there was a very interesting, I talk about him a lot, Brax. He was a German physician who talked about stages of Parkinson's, and he noticed that in the prodromal or the pre-motor symptoms that people can have autonomic dysregulation and a lowering of their blood pressure before diagnosis. A study by Marola et al. Estimated that orthostatic hypertension generally can be worsened by 20% over a year of a person with Parkinson's. And he also noted the huge impact this has on people's quality of life in regards to falls and feeling unwell and not wanting to do things. We do know it does worsen with anti-Parkinson's medications, but it is not the sole mechanism. So what we recommend then, that we have to play a bigger role in screening for people with neurogenic orthostatic hypertension. And so another article by Biswan, Carabin and Turner talked about the role of nurses and nurse practitioners in recognising, diagnosing and managing this. It's an excellent article and I've been sharing it with my colleagues to identify patients who are at risk of neurogenic orthostatic hypertension. We'd also consider too that with people who have postural drops in orthostatic hypertension, it may be also indicative of a Parkinson's plus syndrome as well. So if these are sort of really prevalent in an early stage diagnosis, we'd start to think about an alternative diagnosis. But we can also ask patients too, what are their self-reported symptoms? When they stand up or when they're getting out of bed, do they feel dizzy? Are they lightheaded? If they're standing for too long, do they feel fatigue? Do they have difficulty walking? Is their vision blurred? And even one description was about pain down neck from the head and difficulty breathing. Do people become confused or foggy and they can't think clearly? Because all these things are definitely a reduction in independence and necessitating a change of life. The reason that these can happen is that I always think about a colleague of mine. She said she's never forgotten the volume of blood that's required in her brain, because I told her it was about 750 mils, which is about the volume of a bottle of wine. And so at all times, we need this blood circulating around our brain too. And so if our blood pressure is dropping, we're not getting that cerebral perfusion or that lovely oxygenated blood to our brain to help us with those functions. We have some screening questions that we should probably always ask people. And you probably can't see them very well, but it's the same questions that relate back to self-reported symptoms. So, have you fainted or you blacked out recently? Do you feel dizzy or lightheaded upon standing? Do you have visual disturbances when standing? Do you have difficulty in breathing when standing? Do you feel like your legs are buckling or you have leg weakness when you're standing? Do you ever experience neck pain or aching when you're standing? Do the above symptoms improve or disappear when you sit down or lay down? That's very significant because it comes back to this notion of postural position, hypo blood pressure. And another consideration was, are the symptoms worse in the morning or after meals? So we think there's a thing called prandial hypotension. It's when you eat a big meal and you release carbohydrates and the insulin, and they can also drop your blood pressure too. And have you experienced falls? Very significant. And are there any other symptoms that you commonly experience when you stand up or within 3 to 5 minutes of standing and get better when you sit or lay down? So they're really good questions that we need to ask people with Parkinson's disease. So the goal of treatment, what do we do to help these people with whose blood pressure does drop when they change position? And from the words of Sam Bolitho, who's a neurologist at St Vincent's, and also I followed this up with Palmer in this article, it's not to normalise the blood pressure readings, but to reduce the symptom burden. So all those things that we discussed, and thereby improving quality of life, and hopefully that contributes to reducing morbidity and mortality, and i.e. presentations to ED when someone may cease your medications and blaming that drug solely. So, and the reason we don't want to normalise the blood pressure or focus on getting the blood pressure correct is because sometimes people are not symptomatic. They don't feel dizzy, they don't feel lightheaded, but their blood pressure can drop, or there's too much focus on getting the right blood pressure. On changes of positions. Okay, so what we can do then is have some other strategies to help normalise the blood pressure without removing medications. So typically we address aggravating factors. And so the story of our 82-year-old lady was that she had actually been on some antihypertensive drugs before her diagnosis of Parkinson's. And so we needed to have a look at those and say, are there any that we can reduce? One of the clients that has called to the info line has asked about the medications to be used with caution and about the role of angiotensin II medications, which are for blood pressure. And it's really to do with this. It's to make sure that if you are taking antihypertensive drugs and you're on anti-Parkinson's medications, that you're not getting a bigger drop in your blood pressure. And in some cases, we've had to hold the hands of the neurologist and the cardiologist and say, we really need to rationalise the use of these antihypertensive drugs because the person's blood pressure is becoming too low, and convince one or the other that we need to not reduce the Medipar, but possibly to reduce their antihypertensive medications. We also look at drugs that reduce your vascular or your plasma volume, such as diuretics, and see whether we can maybe get rid of those. It's often good to investigate and treat anemia as well. And we also like to give lots of patient care education to, like with some of these sessions, to understand the mechanisms of orthostatic hypotension. And it's not just about having drug treatment to fix it. We talk about, the risk of sudden postural changes, I tell people to have an escape route if they do get up and they feel that they're going to faint or they're going to have a syncopal episode. Where can they fall? One man I looked after, he had a beanbag in the middle of his lounge room because every time he got up to go from the table across to his lounge chair, he often felt very dizzy, even using his four-wheelie walker. So he had a beanbag in the middle. If he did fall, he'd throw himself into that. Being aware of heat exposure. So if you are standing in the shower, it's, we're facing this hot weather where you may become a bit dehydrated. When you're hot, your vessels dilate, and that can also cause a drop in your blood pressure too. And a lot of people then say, well, I'm just going to lie down because I feel awful. And I know that one thing is that prolonged recumbency, which just means lying down too long, also worsens this orthostatic hypotension. So bad news, guys. You don't get off lightly. You've got to start doing some exercises. So what are the non-pharmacological strategies? We suggest sleeping in a head-up position, a bit like a tilt table. So not what we call a Fowler's position, where you're bent at the hips, but more like this. And people say, well, how do I do that? And the object is actually to chock up the head of your bed, or you get a lovely tilt bed from a referral from an OT. Arising slowly from lying to sitting to standing. And people with Parkinson say to me, you must be kidding. I'm always arising slowly. Not standing too long because blood can pool in the lower extremities. So you can see this lady hanging out the washing, arms are up, tendency for the blood to drop. So that doesn't mean you can get out of actually hanging out the washing. It just means to make sure that you have regular breaks and that you're sitting down, perhaps in between. Drinking water, well, we know we bang on about drinking water for bowels, but it's also good for increasing your plasma volume of blood and adding a bit of salt. Anytime you ever get to add a bit of salt to your food. Some people actually have a neurologist that will recommend salt tablets as long as you're drinking water, because it's a process of osmosis where you're pulling water into your system. Exercises, I said you can't lie on the lounge if you're feeling awful and standing up. You've got to avoid the deconditioning because it worsens neurogenic orthostatic hypotension. And an exercise physiologist or PT can give you some good exercises to target these issues. And they call them counter maneuvers, like squatting, bending over, bending forward, crossing your legs, toe raising, all these things to help drive up blood pressure. You can exercise in a recumbent, so a reclining position if you need to. And I did hear about swimming. It's great because you can't fall over in a pool. And there was a fellow that was doing that recumbent cycling. I've got a link here, and I'm not sure if we might send that out to the folks, Stacey, and it actually has exercises that somebody could actually take to their physio and talk about the physical counter maneuvers that can help raise orthostatic hypotension. There was a lot of discussion about the use of compression garments, and so there were some studies done, and they looked at the difference between using compression stockings, and they noticed that they are difficult to get on and off. They have to go all the way to the waist, and they weren't really well tolerated in our cohort of people. I can say probably if it's really hot, they'd be quite a bit of a disaster, but I suppose, it's an option. What we did find, though, that abdominal binders had really reported to ameliorate those orthostatic drops in people in some patients, and they were better tolerated than compression stockings. Again, risk and benefit of having to wear like a corset device in the heat, but I guess if you're feeling really dizzy and you need to stay upright, then these are the strategies that we can recommend. This was supported by a study that was done in 2016. There was only 15 randomized patients, and they, in this study, they had a placebo and an abdominal binder, and they noticed significant reduction in orthostatic hypotension. So another anecdotal study was actually a patient with a Parkinson's plus syndrome, and every time he sat up, he just felt dizzy and fainted. And we finally got the use of these abdominal binders with the help of the physio. And I was so delighted one day when he and his daughter rang me from a coffee shop to say that he was sitting up having a coffee, and that was the first time he'd been able to do that in some time. Another study came out and blew the water out of all the treatments that we recommended. And it had weak recommendations for water drinking, salt, sleeping in a head tilt up, physical counter maneuvers, stockings, limited evidence. Management should be tailored and tuck, we said. And one neurologist said to me, well, I don't know if those people actually look after people with Parkinson's disease, but we certainly, even as a, from basic principles, that drinking water and a bit of salt and these things actually did provide some improvement in people's dizziness. There was strong use for abdominal binders, which we'd seen in the other study, and they also recommended the use of some pharmacological medications. And that was in 2017. So we move along to those. And I guess if you've gone through all the non-pharmacological strategies, it's always good to try things at a time. Then out of the International Movement Disorder magazines that they do their periodic reviews, these are the interventions that we say to treat autonomic dysfunction in PD, so it's quite clearly recognised, and there's a regime of drugs. So fludrocortisone, which is what that lady was actually taking at the time, and then another drug called midodrine, which is possibly useful, another drug domperidone, which we know we can use for anti-nausea, but they felt that that might have some role in orthostatic hypotension. And there's another drug called droxidopa, but I don't believe it's on PBS in Australia. And this is taken from the movement disorders volume. So just a note on that, those medications. So midodrine comes in two formularies. It's a vasopressor. It's really important that people are sitting upright to take midodrine and that you stay upright, because if you take the medication to push your blood pressure and then you lie down, it's going to push it up even higher. And so therefore we don't recommend that you take it within the 4 hours before bedtime. Fludrocortisone is a synthetic mineral corticoid medication. It's contraindicated in people who might have congestive cardiac failure or chronic renal failure. That's why we monitor for potassium and we check for ankle edema. And it can lead to sustained hypertension in a supine position. I can have a quick talk about that. And you need to store it in the refrigerator. Another drug that people use is actually a drug mostly used in myasthenia gravis, but it's called Mestinon. It's an anticholinesterase, and it can be used also for people with Parkinson's and orthostatic hypotension. There's an upward titration, but it is an anticholinergic drug, so we also have risks about using it in an elderly population for its contribution to confusion. So supine hypertension, what does that mean? I tell a lot of people the story about one of my very first Parkinson's patient. He was he used to put me down as his next of kin. He was very naughty, but every time he presented to ED, I would get a phone call to say that he had arrived. He fell over in the Westfield shopping centre at Bondi Junction, and he arrived down into to St Vincent's ED. He was connected to the monitoring system, and his blood pressure, because he'd been lying down for some time, was actually quite high. I think it was about 230 on 130, and that warrants another investigation because, of course, high blood pressure, the issues around that is the risk of stroke and heart attacks. So supine hypertension, supine just means, well, that's how we say nursing, lying face upwards or lying down, and hypertension means high blood pressure. So if you've got orthostatic hypertension or from autonomic dysregulation, it means that if you lie down, your blood pressure can swing the other way and can be very high, but it's not due to cardiac reasons. It's not due to your heart pumping away. I need to go back into the databases and look at the risks for people with really alarmingly high blood pressures with supine hypertension. My assurances have been from neurologists that it is to do with the autonomic dysregulation, not a cardiac issue. So the risks of stroke and risks of stroke and heart attack may be a bit different if it's cardiac, but it's still nice to have those reassurances, wouldn't it? And sometimes the neurologists might chart a very low dose antihypertensive for bedtime, if that makes sense. Okay, and which kind of, it always feels like a really weird thing that in the daytime your blood pressure is so low that you've got to take medications to drive it up, and then at nighttime you're taking something to put it down. But I guess that's the nature of the pendulum. This is actually this link on the website, and it just talks about it's about autonomic dysregulation and how blood pressure is not to do with the heart, but to do with these other changes that to do with the autonomic nervous system. And if we can send that link out, and you can have a look at it if you're really, really interested and you're nerdy and can understand it. But it's to do with carotid and these are aortic baroreceptors and how they affect blood pressure too. And the parasympathetic nervous system, and the sympathetic, which is to do with our autonomic nervous system.